Does anybody think we're going to need the box up here to hear? As long as I'm talking, it's okay. Okay. Well, I was scolded last night, so I didn't talk loud enough. So I'm gonna make sure I talk loud enough today. First of all, I want to thank everybody for coming. We were hoping for a bigger crowd, but you know what? It's a beautiful day, and like I said, told other people they have kids and grandparents with kids playing ball and all this. So, but it's a subject that's obviously near and dear to my heart. I've had experience with it in my family. My dad lost a farm originally because of health care that didn't pay expenses. So when he was able to get back to work, he and Mom saved their money and bought another 100 acres, and that allowed them to get back in farming again. But it was the health insurance that didn't pay that broke them the first time. So everybody in here, I think, knows me, maybe some that don't. My name's Franklin Delano Ross II. We have another FDR running in this election. And it's about damn time is all I have to say. But because we need another one. But I am running for Congress in Missouri's 8th district. It's the reddest district, the poorest district. We have, by every measure, economic-wise or health-wise, we're the worst in the state and one of the 10 poorest in the country. We have the highest infant mortality rate. We have the highest number of people on government assistance. We have the highest poverty levels in this district. We have the highest unemployment levels. We have the lowest amount of college-educated people in this district. So I'm running to help change that. But this is not going to be a political issue today. We want to concentrate on healthcare, which is a big part of my platform. Married to Sandy, tall lady in a white skirt here. She's really the brains behind the operation. She tells everybody I drive and talk, and that's all I'm good at. But I can drive and I can talk. She does everything else. I'm parent to 2 sons. Jared, I raised as a single parent. He died 4 years ago Wednesday from a heroin fentanyl overdose. My youngest son, Clay, is top 40 morning DJ in Evansville, Indiana. And if you ever met him, you know why. He is perfect for it. But to get back to health care, 2/3 of all the bankruptcies in this country are over medical debts. 100 million people, and I have met several of them as I've started talking about this in this 8th district. 100 million people in this country carry some form of medical debt. To me, that's outrageous. We're the richest country in the world, and it shouldn't happen. It just shouldn't be that way. Okay. We've had 6 hospitals close in this district in the last few years. We've got another one hanging on by a thread. Hospital in Hayti, which is in Pemiscot County, way down in the Boot Hill. It's the county you drive through on 55 before you hit the Arkansas line. 92% of the people that come through that hospital are either on Medicare, Medicaid, or both. 8% have commercial insurance in that hospital, and they're just hanging on because this state refuses to fund Medicaid like it should. They try every way they can to cut Medicaid funds, which they're doing a pretty good job of. And the hospitals don't get paid. They go out of business. When I go to Kennett, which is also in the Boot Hill, I pass by the hospital. It's been closed for a few years now. And it's that way all over this district. And like I said, it doesn't have to be that way. I was reading an article this morning, and it couldn't have been any more pertinent to what we're going to talk about today. There's a 5-year-old kid. His name's Kason Rowe. He was diagnosed, forgive me if I butcher this term, doctors, hypopigmented mycosis fungicide skin lymphoma. That's what he has. It's a type of skin cancer. The treatment is a photodynamic light ray, but guess what? Insurance won't cover it. So they're having a fundraiser on, June 19th at the local firehouse. They have a GoFundMe page set up. This is our healthcare system in this country, where you have to have GoFundMe pages and private people trying to put together fundraisers to pay for our health insurance. It's just, and we've let it happen. 1/3 of all the costs on our health care go to administrative costs for the health insurance companies. Medicare is what, 1 or 2% administrative costs? That's a big difference. That's a big difference. So we can do this. We just have to push through the propaganda and the money that the insurance companies and the pharmaceutical companies throw at this. But this little boy brings home, what we face in this country. We are a for-profit healthcare industry. And don't ever forget, profits come first. Before anybody's healthcare, profits come first. I'm going to introduce Dan, my co-host today. Dan decided to throw his hat in the ring for a office. He's going to run for state, or is running for state rep here in District 97, which is Fenton and northwestern Jefferson County. Got in. Dan and I met a few months ago. I reached out. Dan does a podcast called Democracy on the Move. And he reached out to me, came to my house, interviewed me, and we struck up a friendship, and it's just gone from there. He's actually done some writing for me, and because he's a much better writer than I am, much more logical, much smarter. So we let him do the writing. But Dan has a guest that he wants to introduce, so I'll turn it over to Dan, and he can introduce his guest.
Thank you, Danny.
Thank you.
Yeah, as Danny said, my name is Dan Schaefer. I think a lot of you guys know me already. Running for District 97. And I would say that medical issues or health issues is one of the reasons why I decided to run in the first place. Oh, do I need to project my voice more? Sometimes I talk to myself and I'm really loud. But, so I thought I'd start off today with a interesting little story. I ran into this guy at a bar about 2 or 3 weeks ago. And I didn't know him, and I just, a random guy, and I just decided to start talking with him, see what his story was. And he told me a very interesting story. He said a few years prior, he had fallen into a portal and ended up on a different planet. Okay, maybe you know where this is going. Anyways, he ends up on this different planet, and I says, that must have been horrible. I said, how was it? Did you survive? He said, oh yeah. I said, it's not so bad. He said, there's people there, just like here. There's people there. There's a whole society there. The sky is blue. Everything's the same. He says, but one thing about the people, he says, they're very, very brutal people. They're very uncaring people. And he went on about how there's a lot of endless wars. There's starvation. There's disease, widespread disease. And there are some people that have it pretty good. They have the resources. They're doing pretty well. But they don't care about anybody else. He says, you could be doing fine. And then if you get sick, you're on your own. And I said, wow, you're painting a picture of like an Armageddon sort of thing here. I says, I'm glad you found that portal and got back home. He says, well, he says, takes a drink of his beer, looks into the distance for a little while and says, he says, I never did find that portal. I'm still here. So I like that story because for a moment anyways, it takes you out of your body and allows you to look at our society as if you were some sort of alien being from some extraterrestrial place. And you sort of see how it works out in our system here. We can be fairly uncaring. And the thing about humans, I find, is that we have a natural propensity for compassion. And if you speak to any doctor, you'll find out that's what they dedicate their life to. A majority of doctors dedicate their life to compassion and helping people. The problem, though, is that compassion has been institutionalized. We now have a system where a doctor can't help his or her patient because there's someone standing in between called the healthcare insurance company. And that's a problem because we can't express our natural propensity for compassion without this company getting in our way. So I just thought I'd mention that little story there because it's I have other stories I could tell too, but I don't want to bore you with that, and I don't want to get in the way of people who have some really good things to say here. First of all, I want to introduce Veronica Shama. She's going to speak to you for a little while and tell you her story. She has a very unique perspective. She worked in Canada. Well, she's from the United States, worked in Canada. She is a behavioral analyst, a licensed and board certified behavioral analyst, And she went to Canada for a few years to work with a company that was doing some research. And while she was there, she had some major health issues. And she was able to experience what it's like being in another country that actually cares about your health more than they care about your money. So, Veronica, if you want to come up here, that's my introduction to you, and I have to give you this microphone too, if you don't mind putting this on. Wait, we're taking a video of this, so that's why I need to have the microphone. Yeah, that worked perfect. Thanks.
All right.
Thank you.
Thank you. Hello. I'm Veronica Shama, and I'm an American citizen, just like everybody in my family. Before moving to Canada, I have one medical experience that stands out, and that's with regard to having mammograms. And most of the women in here have probably had at least one. And so back in 2012, before we moved to Canada, just prior to that, I had had 2 separate mammograms, and each one with insurance, my out-of-pocket portion was $700. So I skipped a few years and didn't go back. Then we had the opportunity to grow professionally, and my husband and I are in the same field, and we were hired by the same company to move to Canada, which to me was a fantastic opportunity. So we got our offer letter to come and work there in May of 2012, but getting the visa process done made it so that we weren't able to come until November, and we weren't able to move until December of 2012. But we got there in December, and I forgot to mention this. So one thing at the place where I had those $700 mammograms, it was beautiful. It was like a luxury spa. There were like aromatherapy, cucumber minted water, ambient sounds. We didn't have to wear a hospital gown. It was a plush robe. And it was just really relaxing and nice. It was just luxurious. And I think that's where some of my $700 was going. So my experience at Canada was quite a bit different. So when we made the move, it was much more involved to make this move than we anticipated. And so we had to do a medical test to move to another country and get a visa. We had to go to a special doctor. And for us, it was one that was about 4 hours away from us. And it took all day to do the test for both of us. And we passed, and we were able to get our visas and able to go to work in Canada. And we didn't know anyone except for some of the colleagues that we met at work, because we were really thinking this was a good idea. I knew that it took 3 months minimum to be able to access a medical card in Canada. They don't give them away. It's really not easy to get, and it's actually not easy to get a visa, and it's not easy to get citizenship. So I purchased bridge insurance, which helped me have some coverage from the time we left the US until the time I had the Canadian insurance. And I was in Ontario. It's slightly different in each province. So thank goodness that I got the bridge insurance, because in January I started having some textbook, according to Dr. Google, symptoms of breast cancer. And I had no family or personal history with breast cancer. I was very physically fit, really active for my entire life. It was really a shock. But because I didn't have the health insurance, I couldn't get in to see a doctor, to get evaluated, to get a mammogram, to find out what was going on. So one day in February, my husband and I were walking around the area we were at a strip mall in this particular instance to just get an idea of where we were living. And there was what we could say like a dock in a box. So dock in a box is just this one little room, probably smaller than this. And it was one doctor, one assistant, and maybe 8 to 10 chairs that were about like this. There was no carpet, no decorations on the walls, no bathrobes, no atomizers, no cucumber ice water. But the doctor was extremely kind. English wasn't his first language, and I think I went out of my way to be respectful and try to understand. I don't know exactly what country he was from, but I had a general idea. And so I was very grateful to him for seeing me. And I honestly don't remember if we had to pay first and then submit the money or what, but it was, he saw us covered, not under the state plan, but we paid for that visit. And in that visit, he did a physical exam and decided that I needed to have a mammogram. And so he referred me to a mammography clinic, which is separate from the dock in a box, its own little box, slightly bigger box. So they did several different images and some blood work. Following that mammogram, I'm going to speed it up. This took a long time to go through each of these things. So following that mammogram, my doctor got the results that said, you need to come back, we have to do another one that's a little bit more in depth. So I went back to do that one, and I'm still emotionally going, la, 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 la. I don't want to hear about it. It's not me, I don't have cancer, I'm healthy. Then after the second time I went, the doctor had an actual diagnosis based on the mammogram, and I'm quoting here, irregular heterogeneous calcifications, suspect neoplastic process. And when I Dr. Googled that, I found out that meant they suspected cancer. I was still in denial, but I followed all the rules anyway. And the next rule was a core biopsy. So think about your very worst mammogram and think about having to hold that position for an hour while they take a needle and use a punch biopsy needle to try and get bits of tissue to let them find out what kind of cancer you have. They were incredibly nice and incredibly patient, and they reminded me, as I was sitting there thinking about it, I have some pets who've been sick lately, and the vets are so kind and generous and caring, and it seemed like that. They weren't treating me like a dog. They were just being very kind and caring. I'm sorry, just hang in there a little bit longer, And with those, they took probably about 20 punch biopsies, and it was really painful, and I was just la 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 still. And they found DCIS, which is stage 0 cancer. And in some instances, it stays stage 0 and it doesn't get worse. In other cases, it can develop into other types of cancer. So with that, and I have a history of exposure to toxic chemicals when I was young, I decided that I needed a double mastectomy. Please come in. So I had to find a surgeon, and the surgeon said, oh, it's just stage 0. So let's do a lumpectomy and radiation. And I was going, I can see myself going in for a lumpectomy, then it's going to be a mastectomy anyway. So can I just get a double mastectomy and just get it over with so I don't have to deal with this? It's too stressful. She didn't want to do that, but we finally came to an agreement that we would do one mastectomy. We did one mastectomy, and I had to find a plastic surgeon to help with the reconstruction for when I woke up. So the pathology from that's when they take the tissue and they chop it slice it into tiny pieces that the folks who do the pathology can look and see if they're abnormal cells. The pathology found that the DCIS was much bigger than they expected. It was 8.5 centimeters, and there was no margin on the chest wall, which meant I was going to have radiation treatment. And that a very much more severe type of cancer was also found a scary one. The doctor took a sample of that and sent it to California to have the genome typed to find out whether or not it was going to be necessary for me to have chemo. Fingers were crossed, even though they were still plugged in my ears, and I was going la la la. But I went numb. It was really tough to hear. You know, the doctor who was so certain that I didn't need to do anything but a lumpectomy, she goes, "You were right to do the mastectomy, and you're going to have to follow through with meeting your oncologist, your medical oncologist, your radiation oncologist, and then all of the other things that are done to search for metastases to make sure that it's not stage 4. So scans, ultrasounds, lots of doctor appointments, radiation treatment maps. I don't know if you've ever had one before, but it really hurts. They put you into the position so that you're right where the radiation needs to go. And then you get tattooed on 4 parts so they can line you up like a compass. And it hurts so bad that I was just wondering, why in the world do some people have so many tattoos? Because it hurts like crazy. And you can't even see them. I can't see them anyway. So I got a medical oncologist, a radiation oncologist. They were both at hospitals that were a little easier to get to than downtown Toronto and a little more rural, but they had their own cancer center. So I was still pretty okay with that. Then by the end of May, there was an infection at the mastectomy site that was pretty severe. We ended up in the ER with blood tests, more doctor's appointments, and IV antibiotics. The spacer needed to be removed, partly because of the no margins on the chest wall and the radiation needed to be done, but also to help get rid of the infection. And the surgeon, the doctor who needed to do that removal, didn't have access to that surgery room again until June 7th. So this is the end of May that it happened. And doctors in Canada who do surgery, they have to rent the space from the hospital to do the surgery. So she didn't have a spot open until the 7th of June, which was another week, and I could be on IV antibiotics. And I was not real happy about it at first, but after giving it some thought, the idea of taking someone else's spot so that I could have my thing treated if theirs had already been identified as needing to be treated, or if they're saving someone's life from a car accident or something else, I was okay with it. I could last that week. So more procedures, MRI, doctor's appointments, medical oncologist sent the cancer sample, I mentioned that. And the results came back from the sample that I did not have to have chemo, which was like New Year's Eve celebration. There were ultrasounds, specialist appointments, other scans, another minor surgery to heal. The wound was open for 3 months. It wouldn't heal. Radiation treatment, 25 rounds were recommended, but I could only make it through 23. My flesh in front and in back it was like hamburger, and had to have a family member fly in from the States to take care of me for the weekend, every 2 hours changing the dressing so that I could be well enough to be able to take care of myself after that. Also during radiation treatment, I broke my foot, and it was my right foot, the driving foot. So a local hospice had to drive me to my radiation treatments. Nurses came to the home to help with IVs, bandages, irrigation of wounds, and other wound care. And when they came, I almost never saw the same one again, but each one brought a good sized box of bandages and antibiotic stuff that I didn't know it was. And my dad was a corpsman, and my mom is a nurse, and my grandmother's a nurse. So I just was so excited to hoard all of this, all of these bandages and such. And I think we still have some, actually. I had a medication that was prescribed to help with the cancer treatment. I was having some trouble with it. It took me a little over a year to go, man, I really don't think I can hang on going with this medication. I met with a different medical professional, and we discussed it and decided that for me, it wasn't really the best thing to continue. so I stopped. In addition to all of those things, it's here in my notes and it doesn't fit yet, but we were playing in a social league softball, and I'm right-handed. It was a right mastectomy, and I did my very best, and I played catcher, and I could never throw the ball even to the pitcher. I used to be very athletic, so everything around that was kind of blown up, even after it was supposedly healed. I joined a local cancer support group. One member had previously had a double mastectomy herself, and her reconstruction she was very proud of, and she talked about it a lot. And she said, "Do you want to see?" And I was like, "Yes, I do." And we went into the women's room and she showed me, and I was like, "Oh my gosh, you couldn't see a scar." It looked completely like nothing had happened, and it was done with her own body tissue. So there were no implants at all. And the procedure that she had done was called DIEP, D-I-E-P, flap surgery. And I don't know if in St. Louis it's done at all, but I know in Cape Girardeau, the doctors are like, "What's that? I don't know what that is." So I just tell them what it is. It's using tissue from your abdomen and using it to create the implants, so you've got your own tissue rather than silicone or saline for your implants. The doctor that did that procedure for me, it took about 1.5 years. It's a pretty long waiting list for this procedure, especially with people advertising by showing you how good it looks. Princess Margaret is one of the hospitals where Stephen Hoffer was working, the doctor who helped develop this surgery procedure. And he had, I think, 6 other doctors working with him, including some of them were residents, and they followed him around everywhere. And I didn't care. I was fine with it. The more, the better. I knew it was a risky surgery or a difficult surgery. 9 to 12 hours it takes to complete the surgery. And that's with people working on both sides the whole time. So I had to gain 30 pounds in order to get this surgery, because they kept saying, you don't have enough stomach to be able to do this surgery, and we can only do it once. So you need to make a decision. So I gained 30 pounds and I haven't been able to lose it since. And I was told to expect 4 days in the hospital after the procedure, and I got 9 days in the hospital. Maybe it's because it was a holiday weekend. I don't know. Maybe it was because there was a scare within the first 24 hours afterwards. They were checking on me, the physicians were checking on me, and I repositioned myself and started a bleed in one of the sides. So I was like, make it stop, do surgery, do whatever you need to. I agree. I know I have food on my stomach. It doesn't matter. My husband had to sit in an empty waiting room with all the lights off for a couple of hours while they tried to figure out what to do. I woke up and everything was fine. It was 8 hours? Okay.
The hospital was closing down around me. I was sitting there.
Okay. You were sitting there for 8 hours?
They said, "We'll get you, we'll be out."
Oh, okay. That's a long time. And I slept through the whole thing. Then there was pathology on the left side, because that was removed in order to replace it. So that was done at that time. And the day before the surgery, I had a mammogram on the remaining side. It was completely clear. The pathology found 4 new places where cancer was starting. They were small, between 1 and 2.5 millimeters, but it was a third, also very aggressive, scary type of cancer. So I went back on the medicine that was making me uncomfortable at first. And even for a shorter time, after 6 months or so, I was like, I can't do it. The oncologist understood after I talked to the other medical professional. And I feel pretty confident that I received medical and mental health care as good as it could possibly have been, especially about not having to worry about cost. So while all of this was going on, during some of the breaks in between, my son was a teenager at the time, and he really loved roller coasters. And there's a place near where we lived called Canada's Wonderland that has 2 gigantic roller coasters. And so we would it was the off season and the kids were still in school, so he was visiting, and we would get in and we would ride those roller coasters over and over and over, and I would just scream as loud as I could. It was my opportunity to get out all of the angst about what was going on. We have a great photo. I'm not doing slides today, so I'm not going to share that with you today. The bottom line to me is that all of this happened at a cost of $0 to us. We didn't have to pay for anything except that first visit, but the insurance ended up reimbursing us. And then we had kind, patient, smart medical staff most of the time. And we did have to pay for parking, though. And some people complain about that. And you do have to pay for an ambulance, but it's like $35 if you have to use an ambulance. So fast forward to moving back to the US. Neither hospital system in the area where I lived, so it was 2018. The last cancer was found in 2015. So I was still within the 5 years where you're supposed to get regular checkups to make sure that nothing else is going on. I could not get an oncology appointment. I couldn't get anybody to see me. I finally got a primary care doctor down where I live to see me, and I thought, how did this guy even graduate from high school? I mean, he's a doctor. I'm not going to this hospital system anymore. I'll try the other hospital system. And they didn't really, he seemed pretty flip about, I'm following up on breast cancer, or when I called to try to make an appointment, they were like, well, where'd you have it done? You should go back there. I'm like, I can't go back there. It's almost as if they didn't believe that I had cancer, even though I had my records and I brought them all in. Also, while I first arrived here, I was exposed to propane. So I had propane poisoning at an Airbnb that I was living in when I first moved here. Went to urgent care because they couldn't turn me away, and I was diagnosed with bronchitis. It didn't get better with the medication that was prescribed, so they gave me stronger medication for a worser case of bronchitis. Then it was not getting better still, and the doctor ordered an x-ray. So there was a chest x-ray that is pretty big. It's not just the chest. They found that I had pneumonia and there was a spot on my liver. So then the panic kind of sets in. So I've already been through all of this other stuff and I can't do the I'm not believing it thing anymore. And I made an appointment to go to the Cancer Treatment Centers of America. And I went to the one in Tulsa that is not there anymore. Now I'm charged for every visit and every lab, so that's about every 6 months when I see the oncologist, and I've decided to continue those 6-month visits because of my exposure to the chemicals when I was young, and that exposure explains my breast cancers. I now have lymphedema, and treatment for that is about $300 each visit before insurance picks up, and depending on what's going on and how well I'm taking care of myself, I have 20 to 60 visits to address the lymphedema per year with a lymphedema specialist. There are several other health conditions that I have as a result of experiencing breast cancer that are probably just going to be part of my life going on. And some of them are extreme enough to keep me from being able to work consecutively and consistently. In March of this year, I had a completely unrelated visit to the emergency room down where I live. And the cost for that visit was, several $1,000s. And my insurance paid for part of it. And then I had my part of it, and I was just diligently paying $100 a month just to get it taken care of. We had a change in our life circumstances, and I needed to let them know I'm not able to pay what you want me to pay, which is 10% of the total bill. Can't do it. And eventually it got to the point where the hospital told me that they were going to send me to collections because I wasn't paying the 10% of the cost, even though I was paying every month. Then one of the other doctors that I see recommended a scan to test for another type of cancer. I couldn't afford to take it. So I let the doctor's office know I can't do this that the doctor ordered because I can't afford it due to these other bills that I'm doing. We have to put it off. Then they contacted the billing office. The billing office contacted me, and they got a little bit nicer. They changed the amount a little bit, and that was where that got to. There are a couple of other procedures that I need coming forward. I'm putting them off as long as possible and not getting the care that I need. And some of the doctors seem concerned, like the ones who called and said, why are you keeping my patient from getting what they need? And others are just like, well, come when you can. It'll be fine. I prefer to focus on healing now than how to pay for what happened. And I believe that if we had not been in Canada during that entire breast cancer experience, we'd probably have been bankrupt by all of the different people that we saw. And the highest level person was just as kind as the nurses who came in and changed my fluids while I was in the hospital. And it's really important that we in the United States can find a solution to this problem that we have. And paying private corporations, they exist to make a profit, we know that. But we need to make some way to find alternatives so that we can find a way for Americans to get better health care. As Denny said, insurance, profit comes first, and that's definitely true. So thank you for your time. Oh.
Okay, well, it's always, you can talk about this stuff forever and a day, but I need my notes too. You hear it firsthand like that, it truly brings it home, right? I mean, it's just, and we not only bankrupt people and all that, but we kill people. How many people do we force to ration insulin or what other medications they need, okay? So people say we have the best healthcare system in the world. We don't. By every measure, we're at the bottom of the list in the developed world, okay? And this just, my heart breaks, for what you've had to go through. I can't even imagine that. I can't. Okay, we have Dr. Ed Weisbart was supposed to be here with us today. He tore a ligament in his ankle, couldn't make it. So he sent two other members of the A team. So our first, they are members, you're both members, right, of PNHP. Okay, it's a nationwide organization of doctors, mostly professionals, 25,000 strong, I think, that advocate for a national health plan program. Physicians for a National Health Program is the name of the organization. They were formed in 1988, I think. But all these people are advocating for a single payer Medicare for all system for everybody. As you can see, it's very much needed. Our first guest I will introduce, looked her up this morning. I didn't have all her bio information. Dr. Priya Pal, that's correct. She works in infectious diseases at Washington University. I'd like to have a chat with you later on some of the COVID things that you've had to deal with. But she is from Florida. She has a BS in chemistry, biomedical mathematics, biochemistry, summa cum laude, Florida State University, right? From Tallahassee. She knows what that means. The Seminoles. She has a PhD in molecular microbiology, microbial pathogenesis, from Washington University School of Medicine in St. Louis. MD, PhD, Washington University School of Medicine, St. Louis. Her residency was at Tulane in New Orleans, Louisiana. So she is our infectious disease expert here today, and she's going to inform you a little bit. Come on up. Here you go.
Hi, good afternoon. Oh, wow. It's so good to be here with you guys today. My name is Priya, as Denny said. I'm a physician scientist at WashU, and today we're going to talk to you guys about some of the healthcare challenges that everybody faces in this country and ways that we can try to address that. So Dr. Fogarty and I will talk about how universal healthcare is a potential solution to some of the problems that we have. So I'm an infectious disease physician. That means that if somebody has an infection in the hospital, we take care of them. So last month, I saw a woman, let's call her Ashley. So Ashley is a 22-year-old woman who's paraplegic from a gunshot wound from a stray bullet that she encountered as a child. And her family is at work to make ends meet. So for most of the day, she's sitting at home in bed and not able to move because she's paraplegic. And I saw her in the hospital because her family had come home and found her unresponsive. They'd found her, and hospital workup showed that she was in septic shock from a bacterial infection that had developed at her bedsore. And so, her family can't afford home health, so she's sitting at home most of the day and isn't able to turn to do the things that are necessary to prevent bed sores from forming. And so a bacterial infection had formed, it had gone unchecked, she had developed septic shock and become unresponsive and ended up in the hospital. The kicker here, though, is that when I saw her, it wasn't her first time in the hospital. 2 weeks prior, she'd already been hospitalized for septic shock for a bacterial infection from the same site. And she'd been discharged with a prescription for oral antibiotics to finish out the course. However, her family couldn't afford those antibiotics, and the infection had gotten worse, and she had ended up right back in the hospital in the exact same situation. We live in one of the wealthiest countries in the world, and yet stories like this are not uncommon. Today, as a nation, we spend $4.7 trillion in healthcare spending. That's 12 zeros. Compare that to our military spending, which is $820 billion. So we're spending 6 times more for healthcare today than we do for military spending, and yet healthcare remains inaccessible and inaffordable for most Americans. So where is all this money going? This $4.7 trillion. Much of this is due to the aggressive financialization of healthcare. Americans as a whole agree that many things should be driven by free market prices. So we are, after all, in a capitalistic society. So things like clothes, food, entertainment, they're all driven by free market prices, right? And most Americans would agree that some things should be provided by the government. So fire departments, public education, and roads are typically things most people agree are provided by the government. So where does healthcare fit into all of this? Healthcare is by nature not a for-profit industry. When people are sick, that requires money to take care of, from the hospitals necessary to the medications to all the staff necessary to run all of these facilities. And you might be thinking, well, the free market works sort of like a magic hand, and if you put anything up to the free market, we should be able to increase value at an appropriate cost. So why doesn't that work for healthcare? So let's try to address that. Let's think about something that we've probably all purchased. How many of us have cell phones? Most of us have cell phones. So what did you do prior to purchasing your cell phone? I'll tell you what I did prior to purchasing my phone. I read a lot of reviews. I talked to trusted family, friends, colleagues, and I thought about the features that I wanted on a phone and compared them with the available phones on the market, found the phone that I was interested in, then looked at the prices at different stores for that particular phone. And at the end of the day, I decided it was too much and I was going to wait for a Black Friday sale. So what are the essential components of this? We have a consumer that has the information available to be able to decide what is the right value that they're looking for. So they're able to understand the market and decide to make those decisions in an informed manner. And then there are transparent prices available for people to decide what is the price point that they want to purchase at. And at the end of the day, they have the choice to walk away and not purchase that item. And so does any of that work for healthcare? So let's say our friend Jack ended up with either a heart attack or a stroke. So at that moment, does Jack have the time to call his insurance company and say, which healthcare system is in my network? Which one has the best doctors? Where can I get this medication? Probabilistically, Jack doesn't have the medical knowledge to even know what he needs at that moment. Is he going to know that he's at risk to have a left ventricular dissection? Is he going to know that he's going to get a coronary artery dissection later? Probabilistically, most people don't have the medical knowledge to be able to know or navigate those answers. At that moment, time is heart or time is brain. And so what he needs at that moment is the first ambulance that's going to get him to a cath lab to either get him TPA or a PCA. And that is, just underscores how healthcare cannot be a free market good. The things that go into driving free market prices just don't apply to healthcare. And even if you take something that isn't an emergency, say, for example, an elective procedure, somebody's having surgery, you can plan that, think about it in advance. You can take the time at that moment, you can think about which insurance company is going to be able to cover that particular procedure. You still probably don't have the medical knowledge to know what labs you're going to need for that particular surgery, to be able to know which doctors to trust, or even to understand the studies to evaluate what should we be looking at, morbidity, mortality here, what are the outcomes that are important. So for all those reasons, I feel like free market cannot apply to healthcare. We talked a little bit about high medication costs at the beginning, so I want to loop back to that. We spend $4.7 trillion for healthcare. About a fifth of that goes towards medications. So that's just shy of $1 trillion. And yet 1 in 3 Americans will report that they cannot take medications as prescribed due to cost. Medications don't cost that much in other countries. Americans pay about 3 times as much for the same medication than individuals in other high-income countries. And that's because other countries do a much better job of regulating excessive drug increased costs. And the pharmaceutical industry has done a remarkable job of lobbying our government to prevent any sort of regulation on drug prices. And their biggest argument for this is that if prices for pharmaceuticals were regulated, then their profits would decrease and they would have less revenue available for R&D. So there would be less ability for them to innovate. It would stifle innovation. There would be no new drugs coming to market. But let's fact check that. Is that actually true? Let's take the most profitable medication to date, Humira. Humira is AbbVie's anti-TNF medication. It's used to treat Crohn's, ulcerative colitis, rheumatoid arthritis, and was FDA approved in 2002. That's when I was in high school. And it was at that time due to come off patent in 2016. So who developed Humira? Humira was actually entirely developed by Cambridge scientists, from the development of hybridomas to be able to mass produce monoclonals, to the humanization of monoclonal antibodies to prevent rejection, to the phage discovery technology necessary to be able to identify the eventual 2E-D7 monoclonal that became Humira. All that was developed by Cambridge scientists. And then it was sold to a pharmaceutical industry, AbbVie, which then took it to market and put in some costs for the clinical trials. So they invested some money into it. But to date, Humira has brought AbbVie $200 billion in profit. In 2012, AbbVie cost $19,000 a year for a patient to take per year. In 2018, when after it was supposed to be off patent, it cost $38,000 a year to take. Today, patients pay $70,000 to $80,000 a year to use Humira, and it is not off patent. In fact, it is protected by 100 different patents that are protecting different aspects of Humira. So with this $200 billion that they have gained in profit over the last 22 years, where is the R&D? Where is the new innovation that's come from all this medication? Have we been able to develop new medications for ulcerative colitis, Crohn's, rheumatoid arthritis that have lower, that are better, that have lower toxicity? No, Humira still remains standard of care. So this medication, this increased profit has not gone to new innovation, which is their whole argument. So every single time that this comes up to Congress to have some sort of regulation, every single pharmaceutical industry will come up and say, no, you're going to stifle innovation. So that doesn't add up. So, you know, all of these different industries are working really hard to prevent any sort of healthcare reform. And ideological smears have been used to block reform to disguise financial interest for decades. And how could they not? With all of these different companies trying to keep a share of a $4.7 trillion pie, it's inevitable. It should be anticipated. But a universal healthcare solution is possible, and it's both financially, ethically, and morally responsible. And Dr. Fogarty will tell us all about how we can make that happen. Okay, thank you.
Guess I'm quicker than I thought I was still. That was very interesting because of the, people don't realize the costs that are involved with this. But one thing I'll add is there was a law passed back in 1980. A senator from my home state, Birch Bayh, and a senator from Kansas that some of y'all may remember, Bob Dole, worked on a bill that was passed that addressed some of these things with costs. They passed a law that with government aid and assistance and money, universities or pharmaceutical companies, whoever worked on a project, they brought something to market, whether it was a new drug or whether it was some other innovation. They did this with government money. They got to keep the patent, okay? But the government had a say in how it was marketed and how much money it could cost. Well, over the years, that law was just gutted a little bit at a time. That's why we have medications that are $70,000 a year or more. I mean, you hear some people on certain cancer treatments that are thousands and thousands of dollars per treatment. So anyway, our next guest, Dr. William Fogarty, MD. I was putting this together this morning and on looking at the information you had sent, and I see you graduated from St. Louis University School of Medicine in 1960, so my wheels are spinning. Well, that'd make him how? I was 2 years old when he graduated from college, so okay, that puts him about he graduated in high school in 52, and all this stuff, trying to figure all this out, but so that puts you about 90, right? You know what really upsets me about that? He has better hair than I do. I mean, give me a break. He's born with all these smarts, and then he gets his hair too. So he did his postgraduate training, graduate school at the University of Minnesota. How'd you like those winters? U.S. Public Health Service at the National Institutes of Health, 1967 to 70. Faculty at St. Louis University School of Medicine, 70-71. Excuse me. Private practice in St. Louis from 71 to 2001. Volunteer physician in indigent clinics in St. Louis, 2002 to present, so you're still practicing. Volunteer physician on 13 trips to Central America. Active in health policy work with the American College of Physicians, 1993 to present. He was kind enough to leave off the other 50 pages of his bio. So I didn't spend 2 hours up here reciting all his accomplishments today, so appreciate that. Thank you for that. So Dr. Weisbart assured me we were in good hands with Dr. Fogarty. So without further ado, we'll introduce Dr. Fogarty.
Okay. Yeah, I was going to send him all 6 pages, and I thought, I won't do that. Well, thank you all very much. I enjoyed the previous presentations, and they've laid out a lot of what I'm going to try to cover also, so I may be redundant here. But what I wanted to start off with was sort of listing what are the problems we faced with the current U.S. healthcare system, and you've already heard a litany of them, and so I may not add a lot to that, but just a few to lay out a few. We have a lower life expectancy in the United States compared to other developed countries by several years, 3, 5, 7 years from other countries. We have higher costs than any of these other countries. The average cost in the U.S. per person a couple of years ago was $12,000 a year. If you look at comparable countries, it ranges from $6,000 to $8,000. That includes Japan, Canada, France, Germany, and Switzerland. So these are not the backwater countries. These are countries with first-class care, and that are getting it for a half or so of what we're getting. Racial disparities are humongous in this country, as you know. Now, not all these are due to healthcare access or lack thereof. There are a lot of other factors that go into racial disparities, but the lack of access to healthcare is a major factor in the disparities we see. A couple of years ago, a fellow named Jason Purnell at Washington U did an incredible study that was published, I believe, about 5 years ago now. Dr. Purnell looked at healthcare and life expectancy in zip code 63105, which is Clayton, and 63106, which is where my clinic was, in the kind of the near north side of St. Louis. And the difference in life expectancy was 18 years. Okay, 18 years. Now, again, not all that's due to healthcare, but a hell of a lot of it is. And the black and white life expectancy difference for the country as a whole is about 5.5 years. So again, it's unconscionable. And mortality, it's already been mentioned that people die from lack of access to healthcare, lack of access to medication, and so forth. And it's said that about 30,000 deaths a year in the U.S. I think it's far higher than that. And finally, income disparities determine who gets healthcare and who doesn't. If you have a good job at a good company, you probably have good healthcare. If you go on the ACA thing, you can get good or mediocre or bad policies. You can get a policy that has a $13,000 deductible. Well, you might as well not have a policy, because unless you get hit by a truck, you're not going to need that. So all these things really point out the disparities that we live with. And then finally, in spending, the insurance company overhead, if you look at about the top 7, I believe it is, large healthcare insurers, their overhead runs from 13 to 19%. And 13 to 19% of the 4.7 trillion that Dr. Powell told you about is a lot of US dollars. And the Medicare overhead is about 2%. The part that doesn't come out in that, what I've already told you, is that the hospitals and the doctors have huge overhead to deal with these insurance companies on top of the 19% they're already ripping off the top. And a large U.S. medical center has more than 1,500 people shuffling paper. A large Canadian medical center has 7. So they're paying, the hospitals and the doctor's offices are paying all these clerks and billing people a lot of US dollars to produce nothing. None of that gets anybody well or makes anybody healthier. So what do we propose? Well, you already heard about PNHP, Physicians for a National Health Program. It's an organization, as Denny told you, that's made up of physicians, medical students, house officers, and a lot of non-physicians also, who propose something called Medicare for All, or single-payer health care. Now, what does Medicare for All mean? A lot of you are on Medicare already, so you already know what it pays for and what it doesn't. But Medicare for All would include all necessary health care, period. That includes inpatient care, outpatient care, mental health, vision, dental, hearing, long-term care, and prescriptions. Everything. There would be no copays, no deductibles, no need to buy a supplemental policy. Now, who's going to pay for all that? Well, it's going to be funded through progressive taxation. Corporations already spend, big companies that give healthcare already spend a lot of money on healthcare. So they'd continue to spend that money on healthcare, but it would go into the single payer system. All of us would pay something. We're already paying something. It would be based on your income, your ability to pay. The bottom line is everyone would be covered, birth to death. No one would be not denied care. And there would be a free choice of physicians and hospitals. No panels, no in or out of network kind of baloney. You could go to the doctor or the hospital that you care to go to. The bottom line, everybody's covered. There'd be huge cost savings. Now, I retired from private practice 33 years ago. And at that time, as Denny told you, I've been involved in volunteer work at 3 different indigent clinics. And this has given me a bird's eye view of the other side of medical care that hopefully most of you have not gotten to see. Patients I see are universally poor and uninsured. The volunteer physicians I work with are terrific. They are able to take care of a lot of stuff. And but what happens when somebody needs surgery or specialized care that we can't provide, or imaging for MRIs or CAT scans or whatever else? These are real questions that come up every single time you go to the clinic. Okay, we do what we can do, but we can't do what we can't do. And so what's the answer is? Well, we can't help you with that. Or we can get you a discount on that MRI. Instead of $1,400, it's only going to be $400. Well, we could tell them it's going to be $4 million. It'd be the same answer because they don't have $400 and they're not going to get $400. So they're excluded from that necessary care in a country that spends more on health care than any other place on earth and gets poorer outcomes and so forth. When I think about this, besides getting angry, I remember a quote that's attributed to Winston Churchill, who was the British Prime Minister that everyone has heard about. And he's quoted as saying, "America always does the right thing, always, after they've tried every other alternative." And I think he nailed it. We have tried every other alternative, and now maybe it's time to try to do the right thing and get over ourselves. So, thank you. What we'd really like to do now, all of us, would be to answer your questions, and we're all willing to give it a shot. And if we don't have the answers, we'll try to find them. Yes, ma'am.
The one thing that's hard to address
Is what?
ageism.
Ages.
I have numerous folks that say, I go to this doctor, he's take this pill, and I'll see you in a couple weeks. And they work and they'll give me a call. And if you call, they'll say, well, Dr. can't talk to you right now, he's busy. Well, that's when you get in your car and you drive up there and you find out just how busy. I would not for 1 second not go in there and march right into where he's at and see he's sitting there having a sandwich or what. I don't care. You got an appointment, you meet it. You tell me to call you, if that ain't working for me, I'm coming to you if you ain't gonna answer the phone. But
She's
people
tough.
aren't gonna do that. They're not gonna do that. Because for one thing, most of the time they don't have a way there. As you age, you lose your ability to drive as good as you should. Here we are, number one. It's Speedy over here. But the thing of it is we still have our concerns and we still have our aches and our pains, and we know one from the other. And if we call you, we need you. We don't need to be brushed off. And this is what's happening with more and more aged people as we age. They're just like, they'll croak in a little while. So, pat them on the back, give them a sugar pill, and send them on their way.
Well, I don't doubt for a minute what you're saying, but
I worked with a group of doctors for
Yeah.
numerous years.
yeah,
All
my
spectrums.
answer is that isn't how we practice medicine for 30. I practiced medicine for 30 years, but if it's really that bad a problem, I'd either one have a talk with them or two find another doctor.
I have seen recently this advertisement on television. This is I mean, I'll probably never make it there, but I can't remember the name of the place. But anyhow, all it is it's a unit set up just for seniors. They don't see nobody younger than that. You got to be a senior. And when you go in there, you have a nurse that sees to you and a doctor and all that. It's kind of like a clinic setting, but that's fine as long as you get to see a doctor and you can address the geriatric needs. But most doctors don't. I have a good general practitioner, but when I need a specialist, I look them up, I run a background check on them, see how many times they've been sued for whatever. I do. I find some of their patients, I do interviews with them. I don't pull no punches. My husband needed a cardiologist. I found one of the top ones in St. Louis, and I didn't never talk to another doctor.
All right.
I went to him, made an appointment. I was fortunate that he was available because my husband, 28, almost 29 years ago, had 4-way bypass heart surgery. I assumed this was his issue. I didn't realize he just getting old and didn't care. No, he's getting old and he's tired. But this doctor, he said, I can't believe he had a 4-way bypass 4 years ago. He said, they're still working. All them shunts. And he said he's got fluid on his lungs right now, but he's COPD emphysema stage 4. So, yeah. So,
Yes, sir.
First off, I feel for you, but wait till you get my age and you'll understand how much worse it's gonna get. But that's not my point.
I'm
I appreciate it.
I'm 80.
I'm older than you.
Good. You made it, I will too.
Yes, but I understand what you said. But then my question is something different. Where in the hell you guys been?
PNHP.
Yes, we need leadership on this issue, and I don't want you to take that personally. I happen to have a physician in my family, a son, okay? I'll stop.
Well, PNHP, as you heard, has been around for a long time, since the late 80s. Getting this through the Congress is just damn near impossible. It's political, and that's fine. And the ACA helped a little bit, filled some gaps, but it by no means did it solve the problem. And so I just got back from Washington for the American College of Physicians, and one of the speakers at the meeting I was at was a lobbyist talking about healthcare issues. And his point was, you just have to keep chipping away at it. You can't, it's not going to happen today, and it's not going to happen next week, but you just have to keep chipping away. And it's taken way too long.
Well,
Mr. Churchill nailed that perfectly. But I don't have an answer to your question.
well, we need contacts. Your profession needs to lead in a lot of issues that are eminent to all of us, but a lot to those people who are not my gender, even, if you understand what I'm saying. But we need medical people carry an enormous weight because you are responsible. You do know what you're talking about. And we need you to advertise. Let us know where you are so that we can come to you and share these stories and maybe organize in a manner that's effective.
But you have legislators
that
that
are
are tying their hands left and right.
Yeah.
That's the problem. So I guess my question is, how do we best support your organization to get a change? And I realize it'll take, it's long, the long game on this, but you've been at it since 1980.
If you want a really short answer, is pay attention who do you vote for.
Yes. Oh, absolutely. The representative for the 8th district currently is
Yeah.
awful. He does nothing for us, and we need a change. But who do we contact? How do we get loud and vocal? And who's our
Join organizations.
Yeah.
Join organizations.
Get involved in politics.
Right.
Yep.
Political organization and find out who you're with.
Well,
It don't take
my
long.
point is, who are we writing? What's our campaign? How do we get this changed?
I think letters to the editors probably have some weight. Write to your local paper or the Post-Dispatch or the New York Times or wherever you like, and work with your local representatives, your town people, your county people, your state people, your national people. Let them know what's important to you. Again, it's a slow process, and the hospital industry and the pharmaceutical industries are spending bazillions of dollars. We have the best government money can buy, and trying to get beyond that is going to be really tough. And so who's voting in the Congress is what is going to determine it.
Can I second that? So I hear your point completely that, how can we all support this change being happen? But you guys are all in this room today because you're already engaged and you're already voting for people that are going to support the things that you want to have happen. But obviously, most people in CD8 aren't. Otherwise, this guy wouldn't have been elected over and over again. So to Dr. Fogarty's point, the more that we are all able to engage with our neighbors and folks that maybe aren't voting in the same way, that maybe don't understand these policies and how they're directly impacting their lives, that's where change happens, because there's too much money for this to change with money, because we are not people that have money, right? So they are very good, and they have decades and decades of experience of ideologically smearing this. So when Medicare was being championed, there was outcry that the United States was going to become a socialist country if we had Medicare. We had health care for senior citizens. And obviously, we have now decades of experience showing that didn't happen. We are still a capitalistic society, and healthcare reform is not going to do that. But there's a lot of money against that, right? There's a lot of money speaking in the opposite direction. So the only way to change is to change the hearts and minds of people, which drives politicians to do differently. And that means speaking out, talking to everyone.
We need a database of information so that we can approach people honestly, and with information that is not slanted in any direction, that is just direct. We don't have access to that. I mean, I hear these stories.
You can go to the PNHP website, and they have there's a
Yeah.
whole bunch of stuff on that PNHP website. Yeah,
Okay.
you can go to.
Is it $50 a year for just an average
Membership?
I believe so,
Yeah.
yeah.
Not much to join.
Yeah,
Yeah.
but even
Most of the data is free.
the
Yeah.
data you can go in there and get.
Yeah,
'Cause I
yeah,
looked at a
yeah.
lot of it this morning,
If
and
you want to be a part of it, you can join as well.
yeah, Barb.
Every time I see a commercial on TV for some drug that I can't buy, that an ailment that I don't have, it infuriates me. And there's one after another after another. We should outlaw being able to advertise on television like that. It's crazy. That drives up our costs.
And
For
Canada doesn't
no
do it.
reason.
Right.
Other countries have done that.
Right, and I read in Missouri Independent this week that applications for doctor residency in Missouri has declined 20% because of our total abortion ban in Missouri. My girlfriend, who was pregnant, lost her OBGYN. She fled to another state, and she had trouble finding somebody to take that person's place.
Yeah.
We're losing our doctors. We're losing yous.
You're losing nurses too.
I have a question for Dr. Powell. Did I say that correctly?
Priya is great.
Okay. So you were talking about development of a drug at Cambridge University, right? So I'm assuming that development occurred through public funds grants, right?
Yeah.
Okay, so we're paying for the development of that drug, but then Cambridge University pretends that they own it. And when you said it was sold, I'm assuming it was Cambridge that sold it to the drug company.
Yeah.
Right? So taxpayers are paying for the development of the drug. Somehow it winds up in the hands of a drug company who does some work, as you said, with clinical trials, but then sells it, makes billions of dollars off of it that we pay for.
Yep.
Yeah.
To me, that doesn't even sound like free market capitalism. That's a scam, right? That's a scam, right out now.
That particular medication, Cambridge in England, but
Oh,
still,
England. Okay.
that sort of situation happens with NIH dollars all the time.
Yeah.
Yes.
That's what I was talking. That's what I was talking about earlier. That the law back with the Bayh-Dole bill was supposed to address that. Okay, but it's been gutted, and Trump basically finished it off when he was in there. So, and talking about our congressman Jason Smith, you go to his website, talks about healthcare. He says that I don't want Bernie Sanders style socialized medicine. Okay, fine. What's your solution? We've had 6 hospitals close in your district. Okay, people don't have access to health care. They're traveling miles now to get to a doctor or a hospital. So what is your solution? They don't have one. Okay, the ACA was the Republican health care plan because the Heritage Foundation came up with that because they keep the insurance companies involved. Okay, that's what was wrong with it. That's why Romney had such a hard time running on it against Obama, because that's what he put in place in Massachusetts, right? So the ACA was not the answer. I think Obama ran with it because he thought he could get it through something, since it was the Republican health care plan. But he underestimated how much they disliked him, so they didn't get it. But so anybody else, Sandy?
So the PNHP is 25,000 doctors nationwide. Is that growing? I mean, do you think
It's grown some. I don't know exactly how much, but I'd say in the last 10 years it's maybe grown 5,000. I mean, it's kind of plateaued.
Do you think the general feeling is doctors feel stifled and insurance companies don't let them practice like they want
No. PNHP is not the only organization that supports healthcare reform. Okay, I'm a member of the American College of Physicians, which is the largest specialty organization. It's about 160,000, and it has published policy papers for the last several years on healthcare reform, and is very active in that field. That's where I was 2 or 3 weeks ago in DC working on that. But so it's not just PNHP. I think if you look, my physician colleagues may not like this, but if you look at a graph of support for healthcare reform, it goes down by specialty, and so internists, family practitioners, pediatricians, probably OBGYNs are very huge majorities are in favor of reform. If you go down to Mohs surgeons, and I shouldn't pick on people, Mohs surgeons and so forth that are at the other end, they probably are maybe not as enthused, shall we say. So, but PNHP has been out front on this for a long time, and the ACP, American College of Physicians, also, and I'm sure the other more primary care specialties, peds, general, family medicine, also are hugely in favor.
Yeah, Lisa, go ahead. You want her to go? Okay, go ahead.
I know the mention of age discrimination, and I believe you completely. But the other end of that is young women. I remember in my own experience, and then also with my sisters and friends, if you're young and you go in and you have something that hurts, getting access to pain medicine, even if it's diagnosed. My sister had like 17 fibroids and uterus and couldn't get her surgery for a month, and they wouldn't give her any pain medicine at all. And this was something that they knew that was there. And I think it was because of her age. And I've asked other young people here in this area, and they say they have the same problem with doctors not.
They're young and healthy, they think. Right? So, yeah. Lisa, what was your?
So I'm from the Boonville, that's where the southern accent comes from. And in Kennett, Missouri, we lost our small rural hospital. But in Jefferson City, we just got the state, if the governor's gonna sign it, to direct $10 million to help us recruit a hospital to come in and open up in our small rural town. We're on the border of Arkansas, where most people, like, it's 3 minutes to the Arkansas border, right? So we're losing the border war because everyone's having to travel out of state. So recruiting a hospital to come in when a small one, when larger hospital facilities are 30 minutes away with far better medical care. But we do need an ER and things like that. So do you have any suggestions other than, the letter writing campaign, and they brought in, Jason Smith to Jason Bean in the State House and all of that. But is there anything our small rural towns should be doing to appeal better to bring in a hospital, to put a small emergency department, maybe like 6 or 8 beds, and maybe like a little small section where people don't have to travel for an hour and a half or 40 minutes or 30 minutes or 2 hours to Cape so they can get chemotherapy? Like, do you have any suggestions?
The only thing I would suggest is that it seems that that's another place where the people need to organize around their local, city, county, regional governments to come up with a way to support that effort, because it's not going to be a moneymaker, for sure. And so, if you want to get United Healthcare to come in there and set that up, it isn't going to happen. So basically it falls on the people, and then also, as I think Denny mentioned, or somebody did, about getting Missouri to better support Medicaid. Medicaid reimbursement rates are, I believe it's under 30% of Medicare. And so that is not going to keep the lights on. Okay. It's just not going to work.
That's absolutely true.
Thank you. I just saw something on television, an advertisement, a couple days ago, and I got into the last of it. But it is something like that, some kind of an emergency hospital doctor set up so that, it's a small thing. I don't know where it was from. It's from volunteer. Yeah, I just saw that.
Yeah, there was some in the paper just in the last couple of days. I can't remember the details.
Yeah, I know what you were
It's just
describing.
an emergency. I mean, if they're not able to stabilize, they transfer.
Yeah. That's and to address Lisa's question, it's not just getting the people there. You bring in a hospital, the doctors, those people are educated. The nurses come in are educated. They want their kids to be educated. They want good schools, and we underfund our schools. We don't pay our teachers. We're last in starting teacher pay. So how are you going to attract these professional people who are well educated that want their children to have special? Kennett doesn't have some nice private school like you can get in Ladue or Clayton, right? So that's another side to this whole story. It's the poverty, complete poverty in these areas, and that's one of the things we have to address. Not just the healthcare part of it, but the poverty part of it. So,
absolutely.
Any other questions?
When old people have the secret language of writing, and the younger ones don't have no idea what we wrote.
She's going to go on cursive now.
That's because they can't read in cursive.
That had to come up.
I know it. And I had that question on a survey here recently about, do you support kids, writing cursive in school? And I'll tell you what, if you'd see my handwriting and what it was in cursive, you would think it was probably written in Arabic. because I can't write worth a damn. So, but yeah, I mean, they don't.
Teaching the kids
but-
things that they need to know.
Yeah, they're good at typing with their thumbs, though. They're good at that. Me, not so much. But so, any other questions for anybody? Anybody? Let's see. Yeah.
Your organization is only for doctors and specialists. It's not that there is a volunteer group for people who want to, like that you can come with suggestions on the side in the organization. You hear my accent, and I know.
Yeah, that's fine. No,
from the Netherlands, so this is really amazing.
So I still I didn't get your first point about.
So what I mean is, can people like me, I work in the medical industry, with suggestions about healthcare, about the payments that the patients have to do, indeed also Medicare, who doesn't pay a lot, Medicaid, I mean, can we come up with questions or suggestions to your organization?
Is there an advocacy arm to PNHP?
Right.
Yeah,
Sure.
I don't know.
Advocacy group. Yeah.
Yeah, well, PNHP has non-physician members also. Again, the name is kind of misleading, but it's not all physicians.
So you can join it whether you're a physician.
You can join, or as they said, you can go online and look at their position papers and so forth.
I just heard about your organization last week, but my husband is Ben Shaver, he's also working, so that's why I think this is amazing. This is really what I like.
And she's had a little experience with she's from the Netherlands, so she's had a little experience with other healthcare systems as well.
Like you said, it is different, but your suggestion is what we have, but it is similar. What we have is like, you pay still like a commercial fee for your healthcare, but if you are, let's say, on the poverty line, you pay less and the government helps.
Yes.
So it is always the same amount, but where you pay 200.
Right.
I'm sorry?
It's prorated.
Yes, exactly. That's how it works.
Yeah. Any other questions from anybody?
What was the other organization? The organization you were talking about is how many?
160,000 members.
American College of Physicians. It's basically the internal medicine specialty organization, and it's the largest medical organization after the AMA. AMA is all specialties. And
so are there any organizations like yours? I know PNHP is non-political. They don't support candidates or whatever. Right. Are there any that do? Yeah. That would endorse a candidate that propose.
Yeah. The AMA certainly does, because they have PACs.
Right.
You know. The organization itself doesn't, but they have PACs that support candidates.
So the American Medical Association has that. Okay. Because I know, talking to Dr. Weisbart, that I said, well, we're non-political, and I said, well, it's not going to be a political meeting, but I'm a politician now, so I had to slip it in a little bit.
We didn't hear that.
So there's a group that I'm part of. It's called Committee to Protect Healthcare. They have done a great job in advocating for healthcare policy change throughout the nation. So they worked in Virginia to help elect both state House and Senate representatives that would support healthcare solutions. They have worked in Florida. They're helping us in Missouri here with the reproductive rights campaign. They helped Ohio with their reproductive rights campaign, and they endorse candidates and support. They are not large enough that they can financially support, but they do endorse and help advertise. Yeah, so Committee to Protect Healthcare. Oh, I'm so sorry. Committee to Protect Healthcare. So they've done a lot of things, but specifically, if we just focus on the reproductive rights campaign, they have helped with the reproductive rights campaign in Ohio, in Florida, in Colorado, so they've done a lot of really good work, and they do endorse candidates.
Okay, good. That's I'll definitely be reaching out to them. So we need all the help we can get. So.
And they need our help.
Yeah.
The Committee to Protect Healthcare is working on healthcare policy change in a lot of different ways, not just a universal healthcare solution. So I think a lot of folks, not as loud as I should be, but
it's for the tape, not for the audience.
Oh, okay. So I think a lot of physicians and a lot of medical professionals feel like a universal healthcare solution, while would be great, is a really far way off. So there are a lot of other groups that are working on more incremental changes that maybe are achievable in a shorter amount of time, like regulation against PBMs, or more transparency in drug pricing, or holding pharmaceutical companies accountable. So just any healthcare reform that would help bring costs down for patients.
Tell them what PBMs are.
Oh, I'm so sorry. So how many of you guys are familiar with PBMs? Good job.
Only because he filled out a questionnaire. They were passionate about that, and I'm like, what is that?
Yeah.
I figured it out just a week ago.
So it's amazing that nobody knows about PBMs, and that's really a testament to how good they are at their job. So PBMs are basically a middleman in the pharmaceutical industry. So if you want to buy, as a patient, you can go to the store, to a pharmacy, and pick up, let's say, an allergy medication. So Allegra, you can buy that off the counter, but you can also get it as a prescription and get it discounted. But say you wanted to buy Allegra, but the insurance company partners with a PBM, which is their oh my gosh. Yes,
pharmacy benefit manager.
My mind just went blank. Thank you for the crowdsourcing on the information. But they partner with a pharmacy benefit manager to negotiate drug prices and decide which medications will be on formulary or not. So say you have United Healthcare. So United Healthcare will partner with their PBM, and their PBM will negotiate with every single pharmaceutical company and decide who's going to give them the best cut of the deal. And so say you want Allegra, but the PBM that your insurance company is with doesn't like Allegra because they didn't give them the best cut on the deal, but Flonase did. So they'll say, oh, we'll put this on our formulary instead, and we'll drive up the cost for the other one so that all of our members will be forced to go to this medication. So the pharmaceutical company will give the PBM a kickback, which will give the insurance company a kickback, and the middleman, the PBM, just takes in profit from both ends. They take it from the insurance company, they take it from the pharmaceutical industry. They are purely a middleman, and they have no other role. And the fact that nobody knows about this secret source of money, funneling money, is just a testament to how good they are.
Yeah, it's amazing things you learn when you dig into this stuff. As a candidate, I mean, I didn't know what a PBM was until I had to fill out the survey, and it was for a union of all things. Yeah, but anyway, any more questions? Yeah, Dan.
Yeah, one. It's more of a political question, so I apologize for that. But you mentioned earlier that you get painted with, you get tarred with this brush of socialism whenever issues about the universal health care comes up. And this isn't just about universal health care, it's about any progressive issue out there. It's tarred with that brush. So what has PNHP, I know you guys, you're trying not to be political, but I'm racking my brains trying to figure out how do you handle that? Because how do you respond to something like that? Or how should we respond to something like that? Because I really need to know.
There's never been any, there isn't, and there probably never will be any movement toward a socialized medical system in the United States on any front. I don't think the physicians would be in favor of it, and certainly the other providers wouldn't be. If you want to look at a socialized system, look at Great Britain. The doctors are employees of the government. The hospitals are owned by the government, and everything that is there is government run. It's like the DMV of medicine. In the United States, what we're asking for is a single payer, which would likely be the government, as it is for Medicare. But they do not own the hospitals, they do not hire the doctors, they do not control the medicine that's delivered. So that's the distinction. And of course, when somebody wants to really get on your nerves about this, they say, you want socialized medicine, to end the discussion at that point. And that is not what we are talking about, or anybody else, I think, that think there's any practical solution to the problem the United States is talking about. It's
yeah, that's a good point, because a lot of people, that's what they think.
It's more of a pejorative term than it is a practical term.
Yeah, yeah.
FDR, the first one, the
Yeah.
original, had socialism running against him. The slang term for the opposition had that term when he introduced Social Security.
Yeah.
Right.
Yeah.
Right.
Well,
It's nothing new.
I found out.
And look at how many people that were against that, and it's all blah, blah, blah. They're still using it, aren't they?
Oh, yeah.
They line
Let's
it
see,
up.
I find most people like their socialism. I don't know anybody who wants to give up their Medicare or their Social Security or their local fire department or police department or their road system, their sewage and water system. So, you know, they're not all against socialism as much as they think they are.
And they don't understand the word social.
Sometimes they don't like that pointed out, but you know, and some of the ones that are most adamant about they don't want a socialist country are all taking advantage of it. You know, I mean, people in the reddest district, which is the 8th district, are on Medicaid, you know, or some sort of SNAP benefits. You know, that's all socialism, but they don't like that pointed out. Farmers don't like that pointed out. And I was a farmer for 26 years, and that's what I told friends of mine. You know, hey, you guys complain about people taking government benefits. You're the biggest abusers of this of anybody. You get your insurance, you know, subsidized to buy a bunch, and you get price supports and all this. Yeah, but we're providing people food. Well, these people are hauling it to market, or they're serving it up in McDonald's or whatever. So, yeah. So the socialism tag gets thrown around, but anyway. So anybody else? Yeah. Okay. Any other questions?
Really, we should be leaders here in Missouri for this, because Medicare was signed in Independence, Missouri, because Truman was the first champion of it.
Yeah.
So it's a Missouri-led.
Yeah. Yeah.
Well, and it took 20 years. I mean, Truman pushed it in the 40s, and it finally happened in 64.
Yeah.
So it's you know,
FDR had advocated for a single payer health
things
system.
don't happen. Things don't happen overnight. So.
That was only 100 years ago.
Don't give up. Don't give up, please.
Anyway, okay. No more questions. Everybody, give our guest a hand. That was great. Appreciate it so much. Thank you. Thank you so much.
Thank you very much.
Thank you, Dr. Powell. Okay, we'll adjourn here. Want to thank Dr. Fogarty and Dr. Powell for coming and spending their time with us this afternoon. Anybody, we've got cards and flyers on the table. Most of you know who we are, or at least know who I am. But mostly I want to thank all of you for taking time out today, you know, to come and listen to all this. So that shows how important it is to you. So we have to do something different, obviously. So thank you for coming.
Thank you. Thank you guys for running in such hard districts.